The pregnant patient is often a patient that increases our pucker factor, if you will, because not only do we have a young patient, but we have an infant as well to worry about. So let's spend some time talking about the pregnant patient. Here's a case of a 28-year-old female. She's 32 weeks pregnant. She's had a worsening headache and shortness of breath. Her husband called 911 because she was acting abnormally. Her eyes were open to voice when you arrived, but she's confused and localizes pain to her head. You notice her airway's clear. She's not using any accessory muscles, but you notice tachypnea and you hear crackles bilaterally. Her skin is pink, hot, and sweaty. Blood pressure is markedly elevated. So remember that blood pressure is elevated for anyone, but for a pregnant woman, that's very elevated. So blood pressure is even in the 140s, raise an eyebrow for a pregnant woman. Her heart rate is 120. She's tachypnic at 32, and she's only satting about 86% on room air. Unfortunately, she's uncooperative. She's holding her head. She's confused. You can tell that her pupils are pearl. There's no facial asymmetry. She's moving all her extremities. But you notice that she's got a lot of edema in her lower extremities. And you even notice on your very thorough exam she has hyperreflexia. The reason that's included in this vignette is that is a big marker of preeclampsia. Hyperreflexia gives you a good indication this patient's at very high risk. When we're thinking about the pregnant population, in addition to our stress level potentially going up, there's a lot of etiologies we need to be thinking about. These patients are predisposed to seizures. They're predisposed to cerebral edema. They can get volume overload and signs of heart failure as well. Going through using our same tools, we want to look at them externally, see if there's signs of difficult laryngoscopy, see if we'll have difficulty bagging them. Supraglottic devices may be useful. Cricothyrotomy generally isn't difficult, but all of these things may have some small challenges. Let's first talk about some of the physiologic differences that we need to worry about in the pregnant patient. Oxygen reserve and depletion are major. So patients have about 20% less expiratory volume when they're pregnant. Now, all of these things depend on where they are in their pregnancy, right? So if they're, 3 months pregnant, it's going to be very different than someone who's 9 months pregnant. So keep that in mind. The extreme end of the scale is the further along the patient is. But they tend to have an increased O2 demand. Their body is doing a lot of work, so they need a lot of oxygen, and they desaturate about twice as fast as your average patient. Respiratory rate will naturally increase, which means as these patients naturally get tachypnic at baseline, they actually get a little bit of a respiratory alkalosis. So pregnant women in late stage pregnancy may have an alkalosis where they hang around 32, and that could be totally normal. So if you notice a slightly low end tidal in pregnancy, don't be too alarmed by that. Take it all within clinical context, but 32 could be completely normal. Their minute volume increases by 20 to 40%, and this is really what causes that respiratory alkalosis. Cardiopulmonary system is compromised as well. So the functional reserve capacity decreases, and they're really at risk for that supine hypotension. So if you have a pregnant woman who you lay back, or even they don't even have to be flat, you can just have them laying in a sort of recumbent position, and you notice their blood pressure is dropping. Remember, they may need that left lateral position. Laryngoscopy and BVM can be difficult. So there's less room for chest wall expansion, which can cause higher airway pressures and difficulty bagging. They actually have a fair amount of mucosal edema. This is due to the pregnancy and the hormones. And they may need a smaller than expected ET tube late in pregnancy. They're really high risk for aspiration. This is because they have more gastric acid, but also there's less space for the stomach. So they have less esophageal sphincter tone and high pressures to the stomach. So as most people know, pregnant women are at risk for GERD and things like that. These are all the reasons. So if I have a patient I have to intubate, I know their pressures in their stomach are higher. I don't want to bag them unless I absolutely have to. I want to keep them upright so that those pressures stay lower. Now, there's some debate about the maternal cholinesterase activity reducing by about a quarter during pregnancy. There's some speculation about the length of a neuromuscular blockade during pregnancy, but in our setting, it really doesn't make a difference how long our neuromuscular blockers are lasting. If we paralyze a patient and they're paralyzed longer than we expect, well, our patient's hopefully intubated, and if not, we'll have controlled their airway by oxygenating and ventilating them by some other means before any of these agents would have worn off. So our approach. In a lot of ways, we're going to treat them similar to the obese patient when it comes to positioning and desaturation. The caveat to that is that a towel roll between the shoulder blades to sort of roll open the chest can be helpful with pregnant women. We'll talk about that more shortly. Anticipate risk of regurgitation. We're going to avoid a nasal route from intubation because these patients have a lot of edema in the mucosa of the nares and they may not have enough nasal opening. Pre-oxygenate them very well. Do know induction agents cross the placenta, but this is all a risk-benefit analysis at this point. What is best for mom is best for baby. Use induction agents. You can use both etomidate, ketamine, or propofol. If you have propofol, it's the preferred agent. Use an NG or rather an OG tube on these patients to decompress the stomach if needed. So again, consider rapid desaturation. Make sure you pre-oxygenate them and denitrogenate them. Optimize their blood pressure. Keep them in left lateral if needed. And magnesium for patients who are eclamptic. Medications, give your induction agents as if they're not pregnant. And when it comes to positioning, think about positioning similar to the obese patient, but that vertical towel roll between the shoulder blades can help. Want them in the head up position. The idea behind the vertical towel roll is it helps also displace some of the breast tissue that may actually inhibit breathing. So these patients may be patients you want to loosen their bra so that the breast tissue can fall to the side and allow for easier respirations.